Good evening. Good evening, everyone. Welcome to Fertility Talk. Tonight we've got a great speaker. It's Dr. Skye de Jongh, and she is from Vital Lab KZN. So thank you, everyone who's joining us. We're just going to wait a couple of minutes, and we are talking to Vital Lab. Dr. Skye de Jongh from Vital Lab KZN. So Dr. Skye, what I'm going to do is, if you can just send me a request to join me, and then I'll accept. I think she is on. I see her there, and we're talking about miscarriages. What caused my miscarriage? So if you join, if you know anyone has dealt with it, and if you have any questions about it, please send us a message in the comments. Dr. de Jongh will be happy to answer some of your questions if you have any questions that you can answer right now. But again, our topic tonight is what caused my miscarriage. So we're going live. Thank you. Hi, Dr. de Jongh. How are you?
Hi, Leanne. Fine, thanks. How are you?
Good, thank you. Thank you very much for joining us this evening on Fertility Talk.
No
And it's quite a big topic. What caused my miscarriage? It's also a sensitive topic we're discussing this evening. So as I said, if anyone has questions for those who's joined us or is busy joining us, if you have any questions regarding your miscarriage, please send it in the comment section. And like I said, it's a sensitive topic. You can also DM us, and I can always email it through to Dr. de Jongh, and I'm sure she'll be happy to assist. Thank you again, Dr. de Jongh, for joining us. If you could just please take a minute or two to introduce yourself, tell us where you're from, what it is you do.
Perfect. Thank you so much for having me. So I'm Dr. Skye. I am one of the gynecologists specializing in fertility at Vital Lab in Mhlanga. And there we not only do fertility, but also general gynecology. And I've been there just over a year now. I've got a couple of partners, Dr. Kobus Kutsia, Dr. York Siku, and Dr. Timberias. And yeah, it's a very welcoming atmosphere, and we often deal with patients not only who've had just the one miscarriage, but patients with recurrent pregnancy loss as well, which we'll get into later in today's talk.
Okay, awesome. So I'm going to start. We're already getting questions, but at the end of the talk, once we've gone through these questions, then we will answer. Dr. Jongh will answer. Dr. Skye, sorry, will answer whatever questions she's able to answer. The first question is, what is a miscarriage?
So a miscarriage is a loss of a pregnancy prior to that pregnancy becoming viable. So that differs, the definition of viability differs somewhat from one country to the next. Generally, it's accepted as being less than 22 weeks. Some countries and facilities say 24 weeks, but those kind of late miscarriages are they're really difficult, and that can be a touchy subject. But generally, prior to viability is the definition.
Okay. How common are miscarriages?
So they're more common than you'd think, and we actually say that it's almost normal for every woman to have one miscarriage. And I know it sounds awful, and we don't wish it on anybody, but you'll often hear that oh, you've had a miscarriage, oh, just pick up and try again. And generally, you'll find that your gynae doesn't investigate why you had a miscarriage the first time, and that is common practice because it is quite common. It's about 15% of the time your pregnancy will end in a miscarriage. If you've had one previous miscarriage, then your risk of having another one is about 15%. Again, but if you've had two, that number goes up to 30%. And if you've had three, and it becomes, once you've had a couple, it becomes more and more likely that you'll have another. The likelihood of a miscarriage is also quite strongly linked to your age. So that number of 15% applies to if you are less than 35 years old. And I'm sure you've heard that, oh, now once you hit 35, then, your fertility becomes an issue. And the reason it becomes an issue is exactly because of this, because your miscarriage rate suddenly goes up to 25%. And that's usually due to genetic problems with the embryo, which I'll go into a little bit later. Once you hit 40, that number goes up to 50%. 50% chance of miscarriage. And once you hit 45, it's up to 95%. So it's very, very strongly linked to age.
Well, I know I never put this in the list of questions, but does your chances increase or become less of when you use a donor egg after 45 or after 40 and you use a donor egg? Are your chances of having a miscarriage lessen? Does it lessen?
So your chance of having a miscarriage does decrease if you're using a donor egg. So the risk of a miscarriage is directly related, in the case of age, to the egg quality and the egg's ability to form an embryo that has a normal number of chromosomes. So that brings us to the causes of miscarriage. And the biggest cause, responsible for about 50% of miscarriages, specifically in the first trimester, which is in the first 12 weeks of your pregnancy. Biggest cause is chromosomal abnormalities in the embryo. So what does that mean? So all of us sitting here have got 23 chromosomes, and each of those chromosomes is made up of 2 parts, 1 part from mom and 1 part from dad, okay? But as you get older, the machinery that ensures that each chromosome is made up of 2 parts gets a little bit faulty. And so what happens is some of those chromosomes have 3 parts and some will have 1 part. And most of the time, that is not compatible with life and will either result in you not falling pregnant at all. So the embryo is abnormal and therefore cannot implant, or it results in the embryo implanting and miscarrying early on. And then in rare cases, you'll have 3 parts to chromosome number 21, which is in fact Down syndrome. And then your baby will survive, but will be affected by Down syndrome. So that is the most common cause of miscarriage. And that's why you'll find if a lady is, say, 42 and is trying to get pregnant and is having miscarriage after miscarriage, usually they'll be at like 6 weeks, and most of the time it's due to a genetic abnormality. In terms of other causes of miscarriages, the next most common cause is something called APLS. So that stands for antiphospholipid syndrome. And what that is an acquired bleeding problem. Okay, so it's an autoimmune disease. Autoimmune means that your body is causing this problem. Okay, it attacks itself basically, and it causes a bunch of tiny little blood clots inside your placenta. So what happens is the blood can't get through from you through the placenta to the baby for the baby to live, and so you end up with recurrent miscarriages. And it's also associated with getting high blood pressure in pregnancy, something called preeclampsia, and having a preterm delivery. So that's responsible for 10 to 15% of miscarriages. The next cause is one where if your chromosomes are a little bit abnormal. So I'm not talking about an extra chromosome or a chromosome missing. I'm talking about if you got the 2 chromosomes, but somehow this top part has managed to get switched over with a part at the bottom here. We call that a translocation. And sometimes you'll never know that you have this issue. And what will happen is when you try to have a baby, then that little translocation doesn't translate well into an embryo, and that can cause recurrent miscarriages. And that's responsible for up to about 10% of miscarriages. So that's another cause. Then we've got uterine problems. So if you were born with an uterus that was abnormally shaped, then that may be a problem. So the biggest culprit here is something called a septate uterus. So you can imagine your uterus is meant to have a flat top. It's supposed to be sort of a triangle shape. Oh, I can't make a triangle with my hands. Okay, wait. Oh gosh. Okay, triangular shaped. Picture it as a triangle. Yeah. And then instead of this flat top, you have a wall in the center like this. And so that wall, that top part of the uterus is exactly where your embryo loves to implant. And so if it implants there, it doesn't have really good blood supply. And so the placenta can't get enough blood to the baby. And so that's associated with miscarriages. So you're born that way if that's the issue. Then other things in the uterus that can also cause the same problem is if you have a big fibroid, which is a benign muscle mass. If you have one of those in your uterus taking up all the space and taking up all the nice blood, your embryo is not going to have anywhere to grow, and you can have a miscarriage. Again, a polyp, which is a soft tissue mass inside your uterus, can cause the same thing. Or if you've had a previous miscarriage and it was treated with an evacuation or a DNC, that can result in scar tissue in your uterus. And what it kind of looks like is, if you can imagine the walls of your uterus getting stuck together and sort of having pillars of scar tissue in between. That's kind of what happens. And so there isn't good, nice tissue for that embryo to grow in, and that can result in recurrent miscarriages as well. And then there are a couple of small things, lifestyle factors, things like obesity, things like caffeine, alcohol, severe stress, overexercise. Some of these things have been found to play a role, but where it's not proven to what degree. So it's really hard to isolate those things. And so all the studies that have tried to prove it haven't really done a very convincing job. Another thing that could play a role is hormone issues. So if you have polycystic ovaries, then you have a 20 to 40% chance of having a miscarriage if your polycystic ovaries are not controlled. If you have an uncontrolled thyroid problem, that is associated with miscarriage. And if you have uncontrolled diabetes, that's also a big problem. So not to say that if you have diabetes or you have a thyroid problem, you will have a miscarriage. If it's under control, it's not a problem. But poorly controlled endocrine problems are associated with miscarriage. And then the last few things are things like infections. So there's an infection called bacterial vaginosis, which is a vaginal infection that has been associated with increased risk of miscarriage. Having TB in your uterus has also been associated with increased miscarriage risk. If your partner is over the age of 50, then their sperm may be affected and may have some breakages in the DNA of the sperm, and that has been associated with increased risk. So we're starting to get to the less common things, but yeah, there are lots and lots of different causes. And at the moment, we're at a point where with the right investigations, we can diagnose probably 95% of the causes of miscarriage, and only 5% go undiagnosed. Well, only 5% should go undiagnosed. And there, I think we're just not there yet with the science, and we just have a little bit more to learn, but in the majority of cases we can find cause.
Thank you. What are the causes of it, or the chances of it happening again, once you've had a miscarriage? I think we touched on that earlier.
So if your standard risk is 15%, and after 70% of people with an unexplained miscarriage, which will be most people after the first one, because your gynae is probably not going to investigate the first time you have a miscarriage. So 70% of those people will go on to have a normal pregnancy thereafter. That's completely uncomplicated. And the evidence has actually shown that your chance of falling pregnant is highest within 3 months of your miscarriage, provided your miscarriage was uncomplicated and in the first trimester. So you didn't need a blood transfusion or anything like that.
Okay.
So your risk is relatively low after 1, but after 2 it goes up to 25%, and after 3 it's up to 45%. So the more miscarriages you have, the more likely you are to have more miscarriages.
Okay. What can I do to prevent another miscarriage?
So after the first one, there's nothing really that you did wrong, and there may not be any problem. Okay, so what is important to understand is, like we said earlier, the majority of miscarriages are due to abnormal chromosomes in the embryo. And under the age of 35, your risk of having that problem is about 30%. Okay, so 30% of the embryos that you make when you're under the age of 35 will be abnormal. And that doesn't mean you have a 30% chance of having a miscarriage. We've already said you have a 15% chance, but you won't even notice those months that you're not getting pregnant. Perhaps you're making an embryo and it's just not implanting. And that's where that 30% comes in. And the reason we know that it's 30% is because when we do IVF, we can test those embryos. We can take a few little cells from what will be the placenta, and we can count the number of chromosomes. So we know that under the age of 35, 30% usually are abnormal. Between 35 and 37, we're looking at closer to 40% are abnormal. Between 37 and 39, 40 to 41, we're looking at 60, 70%. 42 to 44, we're looking at 80% abnormal. More than 44, 90% abnormal. So it's not, you cannot do anything to prevent a miscarriage if it's going to happen due to a genetic abnormality like that after the first one. So don't think that, oh my gosh, there's something wrong with me. I've had one miscarriage. Definitely not. You're probably in the 70% that are going to go on and be completely fine. Okay. What I would suggest is to try to keep your lifestyle factors under control, because those things are in your control. Okay, so getting a BMI to be between 18 and 25 is optimal. Limiting your alcohol intake to one unit a day maximum. Limiting your caffeine to less than 4 units a day. Limiting your unhealthy foods, so just trying to have a healthy diet, having moderate exercise. They say more than 7 hours of exercise in a week can be associated with infertility, but the link with miscarriage is tenuous. And then taking folic acid, or folate rather. So folate is fantastic. It improves your fertility and decreases your miscarriage rate, as well as decreasing your chance of having a neural tube defect. So optimally to take it for 3 months prior to conception. Then the next thing, if you've had more than one miscarriage, then I think it is a good idea that you get investigated as to why this keeps happening. So the best thing to do would, when you start bleeding, immediately go and see your gynecologist, okay? And the reason for this is that you don't want to have your miscarriage completely at home, because then what will happen is you arrive and, okay, cool, now you don't need an intervention, but we don't know what caused the miscarriage. Whereas if you come prior to the baby coming out, then we have the opportunity to do what's called a hysteroscopy. So we can put a little camera inside your uterus, and then we can take a little piece of that placenta and send it off for testing to find out, is the embryo genetically normal or not? Because if the embryo is genetically abnormal, we can stop right there and know, okay, there's nothing wrong with your body. This is part of a normal process, and we need to either, if this has happened more than once, then perhaps doing IVF and testing the genetics of those embryos and putting back a normal one is indicated. But if it's only your first one and for whatever reason they've done testing, then chances are it probably won't happen again. So that's the first thing, is checking the genetics. Then the second thing, if the genetics come back normal, then you need to have hormone tests. So those come in the form of your thyroid function, your sugar, your prolactin, and then your doctor may want to do something called a karyotype, which looks at your chromosomes to make sure you don't have that translocation thing I was talking about. And then definitely to do a sonar. A 3D sonar is ideal, but a normal sonar is also fine, just to assess your uterus and to assess, do you have one of those little walls in your uterus or fibroid or something that can be operated on and fixed rather simply to prevent this from happening again.
Okay, so I just want to go through some of the questions we had. What are the causes of a chemical pregnancy?
Okay, so a biochemical pregnancy is a pregnancy where you have had a positive pregnancy test. Okay, so biochemical refers to the a blood test. So a biochemical blood test is that pregnancy test that we do on the blood. And so you had a positive pregnancy test, but then when it came to do a sonar, there was no baby there because it implanted and then it must have miscarried, so you got a period thereafter. Yeah. So this is just a very early miscarriage. So in all likelihood, it's probably due to an abnormal embryo, so the genetic cause, like in the majority of cases, but obviously I can't say for sure. But usually when it's that early, it's due to an abnormal embryo.
Okay, there was actually one quite a big question right at the beginning. It was, I know a lady said that she had 7 miscarriages. She's a lady of 37 years old. I had 7 miscarriages so far. Nothing discovered the causes. It's so frustrating. Do you have any advice for something that we VitalLab can offer?
Definitely. So you definitely need to be worked up. There's certainly a problem there. So you need to have a sonar. We need to assess your uterus, make sure there's nothing inside. We need to do those blood tests, possibly do a genetic test for you. I'd be interested to know whether any of those miscarriages were tested for genetic testing. Unlikely at the age of 37, like I said earlier, your risk of an abnormal embryo is only about 50%. So out of 7 pregnancies, you should have come right. So it's likely to be something else, perhaps APLS syndrome. So perhaps you need to be on blood thinners like aspirin and Clexane in the next pregnancy, but we need to do some blood tests to investigate, and I'd be happy to assist you with that.
Awesome. And this way, if you've just heard what Doctor said, please give it, you can pop it an email, or you can DM me and I'll send your details off to Doctor. If you could just give your details for other women, the ladies can contact you.
Sure, I'll definitely do that. I'll put my email address on the comment section.
Okay, perfect. Thank you very much, Doctor. If there's anything you want to say before we go?
I just want to tell the ladies out there that just because you've had a miscarriage doesn't mean you are infertile, and it does not mean that you can't have children. A lot of these things are relatively easy to fix. Those hormone issues, we can give you medication and sort it out. If it's a bleeding problem, we can give you medication, we can sort it out. If it's a uterine problem, we can do an operation, we can sort it out. If it's a genetic issue, we can do IVF, test those embryos, and put back the normal ones. So only in 5% of cases can we not find a cause. So you're very likely to fall in the 95%, and I'm sure we can help. So make an appointment and let's see what we can do.
Awesome. Thank you very much, Dr. Skye de Jongh, and she's from VitalLab in KZN. And thank you everyone that joined us this evening. Dr. de Jongh will be putting her details in the comment section. And if you can't get hold of her, they've got a website, vitallab.co.za, I think it is. And you can always just email, I think it is info@vitallab.co.za, or it's .com, not sure, .co.za. Or you can .com. Yeah, so info@vitallab.com, and you can always just DM me and I will pass your details over to Dr. de Jongh. Thank you very much and have a great evening, Doctor, and everyone else.
Thank you. Thank you. You too. Bye-bye.
Pleasure. Bye.